Spontaneous bacterial peritonitis, or SBP. This is a peritonitis that is spontaneous and it's bacterial. Next slide. All right, so what happens is that you have a translocation of bacteria that are coming from the gut. So you got 1, 2, 3 guts there, and they're coming into these nice, like I said before, wild west of acidic fluid where there is very few patrolling cops or sheriffs in town, right? So there's not a lot of good blood supply there, right? The blood supply that is there is maybe at the abdominal wall, and then they have to make their way, or for the GI wall, and they have to make their way to find the bacteria before they proliferate to a point where it causes inflammation, right? And when it inflames, of course, it's going to cause a widespread bacterial peritonitis, peritoneal signs, or fever, belly pain, etc. But actually, 10% of them don't even have any symptoms. So it doesn't really always, equate to peritonitis. But when you have a patient that has infection, like this patient here, they're then at risk for widespread SIRS activity, right? Systemic inflammatory response, and that causes vessels to be leaky, and that can put us at risk for a variceal bleed, right? So variceal bleed or a hepatic encephalopathy can develop as well as the blood-brain barrier gets leaky. So that is really the consequence of this, right? So about 70% of patients will develop this again if they have it, and then they could just have the fever and not feeling great, or they could have a GI variceal bleed, which is a really high mortality, which also leads to further variceal bleeds, right? Same thing with like ascites. I didn't point it out, but ascites has a high risk of getting ascites and parasites again and again and again. And I think it was like 5-year mortality for ascites itself, just having ascites, is like 44%, right? Which is on par with almost like pancreatic cancer, right? So it is a really high, once you get to the stage of having frequent ascites and frequent parasiteses, you're developing SBP, you're at the end stage of cirrhosis. Okay, so GI tract leaks bacteria into the acidic fluid. It's usually gram-negative stuff like E. coli and Klebsiella. There can be some gram-positive stuff in there, so that's why we usually try ceftriaxone. Usually, fluoroquinolones we're going to try to avoid, so usually ceftriaxone is going to be a good something to start to begin with, right? And then what else? So they might even be on antibiotics like indefinitely, but again, Abdomens is going to make its third appearance, right? We used it for 2 other things. What were they? We're using it for SBP. What other 2 things was Albumin for? They were for ascites and for LVP, right? So which was kind of ascites, right? So you're cheating. What's another one? Hepatorenal. That's the one, right? So you've got hepatorenal syndrome and ascites/LVP. When we do large volume parasiteses, we need to have albumin at 6 to 8 grams per liter removed. Hepatorenal, it's like 1 to 1.5 grams for the first 2 days. This one, same deal. We're doing about 1 to 1.5 grams per kilo, and we're going to be giving that until their SIRS or fever resolves. Okay, so the signs are going to be hepatitis, peritonitis, right? And you're going to have some hepatic encephalopathy in there because our blood-brain barrier is going to get leaky because of the SIRS response, and ammonia is going to travel on through that blood-brain barrier to make them be symptomatic for their hepatic encephalopathy. Okay, and again, as we mentioned before, beta blockers are discontinued indefinitely. They were given for variceal bleeds, but once someone develops SBP or someone develops hepatorenal syndrome, then beta blockers are off the plate. We're not doing beta blockers anymore. Okay. What else? So paracentesis needs to be done to figure out, make sure it wasn't a bowel that perforated or an ulcer that perforated. So we usually do a paracentesis is in the works, is on the menu for someone who comes to the hospital with SBP. Okay. So they might need antifungals as well because fungi like to live in the bowel. So if they're really, really sick and they're not getting better with regular antibiotics and albumin, they might need antifungals to help out. Okay, if they're getting a shock state, are we going to give them a lot of fluid? No, it's going to worsen someone's portal hypertension, worsening someone's ascites. So fluid does not make sense with someone with liver disease, right? So early vasopressors is what we would be utilizing for these patients, right? How do we know someone has SBP? They got white blood cell count, they got turbid peristitial fluid or acidic fluid, So that's the idea with SBP, is that it's a complication that happens from ascites, which happened from portal hypertension, which happened from liver cirrhosis, which happened from hepatitis B, C, or ETOH, or Wilson's disease, or hemochromatosis, right? So it's like a complication with a complication with a complication. So then hepatic encephalopathy. So as we mentioned, this can develop because of SBP, all right? So we have some, or can point that out here. We got SBP is damaging this membrane right here, this blood-brain barrier, right? So we have some ammonia that's being produced by the bowel, right? Ammonia is being produced, and then if we develop an SBP, that's going to potentiate and make these glycocalyxes and these endothelial layers more leaky, and therefore ammonia can then, that's being produced here, this ammonia being produced can then make its way across the blood-brain barrier, and it could get into the brain and cause issues, right? What issues does it cause? It technically converts glutamine into glutamate, and that should ring some bells, because glutamate was what got stimulated with calcium release and caused all kinds of problems, right? So it's going to cause problems. Them being altered, right? There's different grades to it, grade 1 to 4, grade 1, impaired sleeping, impaired handwriting. I promise I don't have hepatic encephalopathy. It has asterixis, right? It has, they can have a stupor state, and it can lead to a comatose state because of this ammonia that's getting pulled into the blood and through the blood-brain barrier, and it's actually osmotically active, and it can cause brain edema as well, right? So they get altered because of a onset of infection, such as SBP, such as a UTI, right? Such as a pneumonia. Just any kind of infection puts at risk for HE, and any kind of infection puts someone also at risk that has cirrhosis for what? For a variceal bleed, right? And yes, hepatorenal syndrome is, any kind of shock state could put someone at risk for hepatorenal too. Okay, so it's a clinical diagnosis. It's not someone that you just say, oh, they got hepatic encephalopathy because their ammonia is high. That's not, yes, the ammonia will be high, but it's not something that can correlate to development of hepatic encephalopathy, right? Someone's walking around doing a Sudoku with ammonia of 210. Someone's giving a critical care lecture with ammonia of 210, right? I promise I don't have hepatic encephalopathy, right? So it's not what's the ammonia that makes the difference. What makes the difference is that they had a blood-brain barrier that got leaky, right? And SIRS or infection is the most common reason why that happened. Okay, you can leak in higher amounts. There are some ways where it can cause it without infection, but like 90% of the time it's because of an infection. Okay, so ammonia is circulating in the bloodstream. Ammonia only comes from one source on Earth, and that is bacteria, right? The nitrate cycle, you learned all the way back in 6th grade science, right? Nitrate was made by the rhizomes in the bean plant of the soil, right? And then the cows ate that, then we ate the cows, and that's how we got ammonia into our system. That's where the N came from, right? Amino acids, NH2, came from the proteins in nature, right? And that it was because of the bacteria that made it. So if there's no bacteria, there's no ammonia. That's why we need bacteria. Okay, so if we want to get rid of bacteria, we give antibiotics, just kind of wipe them out. It's all done, right? And that's what like rifaximin, for instance, is used for. Okay, and we'll talk about lactulose as well, which also helps reduce someone's ammonia. Okay, what else? So excessive gut bacteria can worsen someone's hepatic encephalopathy, put them at a higher risk for hepatic encephalopathy. The TIST procedure, as we mentioned, all this bacteria just bypasses the liver, and the liver can somewhat negate some of that because it has cirrhosis, and that could lead to a worsening hepatic encephalopathy. Usually when patients have a history of HE, TIPS is like a relative contraindication, right? And then hypokalemia puts someone at high risk for hepatic encephalopathy because you will actually make more ammonia when you have a hypokalemic state, right? When you're hypokalemic, you're acidotic, and you're going to make more ammonium, which is NH4, right? NH4 is ammonium, right? And ammonia is NH3, okay? Excessive protein, this is very, very debatable, and it's actually been disproven that, if I take a more protein diet, that's going to make more ammonia. It does raise your ammonia levels, right? As I think I point on the next slide, we have the pathway of how that happens, right? When you intake more protein, you make more BUN with a healthy liver. And if you have an unhealthy liver, that process gets stopped and you start making more ammonia, right? Like halfway through. The NH2 from the amino acids, because it gets broken down, and that then forms ammonia, right? So yes, that happens when you have excessive protein intake, but that's not what worsens someone's disease process. It's actually not beneficial to eliminate someone's protein when they have risk factors for HE. Okay, so sterexis can be HE, but also we talked about high CO2 can have it, and elevated BUN can also cause sterexis. So how do you fix it? So what's the fix? So lactulose and rifaximin. Usually lactulose is first, and if they still have HE, then we'll add rifaximin. Rifaximin makes sense because we're going to eliminate all the bacteria. Bacteria produce ammonia, so if I eliminate the bacteria, that's going to reduce my episodes of HE, right? And then lactulose. So it's given however you can, either by mouth or per rectum if they come in intubated, right? And when they have a variceal bleed, for instance, and why they have a variceal bleed? Because they have an inflammation nearby, and they came in altered. So they're altered because, was it the GI bleed? Well, it's probably because of the hepatic encephalopathy. How do you know someone has hepatic encephalopathy? Yes, it could be clinical symptoms, but if someone's ammonia is high, that kind of clues you in. But we don't keep checking ammonias because we know that that doesn't relate to the disease process and getting better or getting worse. So what is needed is just, do you have cirrhosis? Do you have these symptoms? Then you could say someone has hepatic encephalopathy. So what does lactulose do? It's eaten by the bacteria, right? They produce lactic acid, which acidifies the stomach and acidifies the intestines. And in acidic environments, the ammonia converts to ammonium, NH4. And NH4, you don't have receptors in your gut or anywhere that absorbs NH4, right? Ammonia itself can cross membranes at will, right? Or it's I guess it's polar. It has ability to cross membranes in high amounts. But when those membranes get leaky, that's when it crosses through the gut. That's when it crosses through the blood-brain barrier. Okay, but ammonium does not. It doesn't have any kind of charge to it. Okay, so that's how lactulose is working. And then if that's not working, or we're going to keep this secret just between us, is if the lactulose doesn't work and the rifaximin doesn't work, you can call the GI doctor and say, hey, can we give some Go Lightly? That'll help out the reduce the ammonia, right? That's a lot of work, right? To give a whole liter, 4 liters of Go Lightly to try to lower someone's ammonia. But really the priority is to fix the underlying infection is what we should be aiming at. Okay, so non-pharmacological, how do you avoid this in the future? So put on muscle mass. The worst thing you could do is make someone NPO, unless they're GI bleed. Then yes, we're going to fix the GI bleed. Then we got to feed them as soon as possible. They need the calories first of all, but also they need protein. So the protein, yes, will transiently raise the ammonia, but the protein should be about 1 gram per kilo per day, because guess what? Skeletal muscle converts ammonia into glutamine. And glutamine is good, not glutamate. Right? We're going to neutralize glutamate, and we're going to take the ammonia, and our skeletal muscle is going to literally get rid of the ammonia in your body. So the more skeletal muscle you have, the less risk of HE you have, because skeletal muscle is going to break down the ammonia, or it's going to neutralize the ammonia. Right? So it doesn't make sense to say, always limit the protein. Well, then how are you going to get skeletal muscle? Right? Also, some building blocks of these enzymes and this process, what are they called? BC, beta, something, chain amino acids, alpha ketoglutarate, and all these other things, they can help eliminate ammonia as well, right? So restricted dietary protein is the worst thing you can do for someone with hepatic encephalopathy. They need to put on as much muscle mass as possible, right? It's really hard to put on muscle when you don't have testosterone, right? So liver cirrhosis patients, as we mentioned, they have elevated estrogen because they can't break it down, and that's going to be a negative feedback to reduce testosterone. So it's really difficult for these guys to put on muscle, but if they can get testosterone shots, and they can start getting more muscle mass, and they can reduce their episodes of hepatic encephalopathy. And of course, they get multiple episodes of this, and it doesn't feel great to be in the hospital in and out. It's expensive. It doesn't feel good, right? To be intubated and extubated. All of those have complications. So we do have other options, and the other option is a fecal microbiota transplant, right? So you get a close friend, and they freeze their poop for you. It gets sent to a bank, and they neutralize it, make sure there's no hepatitis A in it, right? Then you could be friends still. And then you give it to you either by colonoscopy, or they could give it to you via a blender. I wouldn't take that smoothie for days, but they would go ahead and they would, they deposit it via NG tube, right? Nursing will deposit it for us. Okay, so that is an option as well. Again, there's different grades of how severe the hepatic encephalopathy is, but the goal is to be on their meds of lactulose rifaximin. They get their put on muscle mass as much as possible, and that can hopefully neutralize the ammonia in the end. So end-stage liver disease. So as you mentioned, ascites puts you at a high risk of decompensation. Portal hypertension puts you at risk for ascites. Hepatic encephalopathy is frequent hospital stays, and coagulopathies can occur. At the beginning, you have your procoagulant. At the end, as your liver really starts shutting down, then you're at risk for more bleeding. Right? Portal vein thromboses can be because of the procoagulant state at the beginning. Hepatocellular carcinoma is still on the menu. That's still up to an 8% risk with cirrhosis, right? If the ascites, HE, SBP, all the other complications weren't enough, you can still now have cancer in the end, right? With unexplained weight loss and worsening liver dysfunction, right? So the idea is to do as best we can. Put on muscle mass. You're going to 2-gram sodium diet. We're going to not restrict fluids. We're going to be as healthy as possible. Wash hands, right? Make sure we don't get infections, so we don't get variceal bleeds and HE, right? And if they do get varices, we got to get them intervened upon as immediately as possible to get banded. And we know if you get banded once, you're high risk of getting banded again and being back in the hospital. So cirrhosis can lead to decompensated cirrhosis, and the only fix for that is a liver transplant or end-stage palliative care and unfortunately death. Right? So infection is a complication. Volume status we know is a big issue. We don't want them to have extra volume. That's going to worsen someone's portal hypertension. Right? If they have a bleeding risk, we have targets of hemoglobin, platelets, and fibrinogen. If they're encephalopathic, we give them lactulose, rifaximin, maybe even go lightly. Right, put on as much muscle mass as possible, and there's screening to make sure that they don't have an active HAV, active hepatitis A. Make sure hepatitis B and hepatitis C have not come into play. Make sure that they're not drinking alcohol. Making sure that they don't have non-alcoholic steatohepatitis. So it's all coming to all these things we have to try to balance as best we can. But as we know, these patients have a high mortality because of the number of complications that can develop. Okay, so we do all kinds of, the gambit of liver tests to make sure that they don't have anything causing them to develop hepatorenal syndrome today or to develop a worsening outcome, right? So there's all kinds of, management of complications that can be very difficult. These patients are very, very complex, right? If even more complex, I argue, than a heart patient or a lung patient, right? Because you have 500 functions to worry about, and just as many complications, just as many symptoms that can develop. If it just weren't for a genetic reason, it could be obviously due to an American reason with fatty intake, or it could be due to substance use disorder with alcohol intake, or it could be due to substance use with IV drug use, for instance, right? Or exposures. That's why HPV vaccines and HAV vaccines are important, and changing diet, exercise is important, right? So all these things coalesce into end-stage liver disease in the end if it doesn't lead to hepatocellular carcinoma.